Welcome to the Derm Vet Podcast, where pet skin is always in. I'm Dr. Ashley Bourgeois, board-certified veterinary dermatologist, skin nerd, and your go-to guide for everything itchy, smelly, and inflamed. I'm here to take the itch out of your day and make derm more fun than frustrating. Grab your microscope and let's focus in. Welcome back to the Derm Vet Podcast. I am coming to you on a gloomy fall day here in the Pacific Northwest, and I wanted to go back to the basics of something, and that is to discuss steroids. I spent a lot of time talking about alternative to steroids when it comes to managing allergies and other, inflammatory diseases. But I just also want to take a step back and provide some relief, I want to provide a way to take away guilt and say this: I still use a lot of steroids as a dermatologist. I am so incredibly thankful for the advancements in my field. I practiced in a world Apoquel, Cytopoint, obviously Zenrelia since it's newer. I have practiced where we had just immunotherapy, which I still love. Of course, you guys know that. Steroids and cyclosporin, as far as like the ways we really had to manage atopic dermatitis. And I am just incredibly thankful that we have other options. I know other options are going to come along the pipeline as well. But sometimes I think we get so excited about those things that we don't recognize that there is still a time and place for these older modalities that we have had because of how complex the disease is that we manage, right? If you just look at canine atopic dermatitis or just skin in general and ears. So I wanted to provide, I've got 6 different situations where I still use steroids. And this can be for other things, like we're going to talk about autoimmune diseases, but also just talking about real life, everyday allergy too. I want to provide, my 2 cents on when I use those, just to provide some, like I said, to take away some of that guilt from you guys. Because when I lecture, sometimes people are like, well, I put them on steroids. Like it's a big secret. Like, oh, I put them on steroids. I'm so sorry. I'm like, listen, I still use steroids. We need them. But I just want to go over maybe the certain situations that I tend to use them in when I'm managing cases in the clinic. Because though I'm a specialist, I am in, again, a busy private practice. I'm seeing lots of cases with lots of different situations as far as what the pet allows, the finances the owner has, what that pet has actually responded to. So let's go over the reasons when I think it's totally appropriate to use corticosteroids in the clinic. Number 1, really severe inflammation. Like those German shepherds that come in and they're just draining lesions all over their bodies. They're like fire engine red. Now, I don't want to say every inflammatory case has to have steroids, because I do think that the JAK inhibitors, potentially cyclosporin, though that takes a while to work, can still help to control inflammation. But there are just cases when that inflammation is really severe, and they're having the draining lesions, and we need a quick way to provide relief for them to make them feel better. That steroids definitely will be the fastest, most effective way to do that. So when they are just super red, and of course you need to look for infection, all the things that we've talked about on the podcast before, but there are just situations where that pet, especially cats, when we're limited on the options that we have, but even in certain situations of really severe inflammatory dermatitis in dogs, there is just a time and the place to say a couple weeks of steroids is going to reset you and do you some good. We're going to provide quick relief. We're going to control the inflammation, and then we can adjust to what makes sense for that pet in the future. Maybe 2 weeks of steroids really helps to clear that inflammatory process up. But maybe then we're going to switch to a JAK inhibitor, or we need to figure out what the allergic workup is for that particular patient. So severe inflammation, draining tracts. I think of really severe pododermatitis, interdigital furunculosis. I am not saying a JAK inhibitor couldn't potentially help those cases, but when they are just erupted nodules all over and really swollen paws, and we've ruled out things like Demodex, we know there's infection there we're going to manage, but they just really need some quick inflammatory relief, then doing a short course of steroids can do wonders for them. So, number one, really severe inflammatory skin. Number two, using steroids in the clinic and feeling guilt-free about it. When we are waiting for a medication that's not as quick, and I'll tell you the most common time that I use this in my clinic is when I'm starting cyclosporin. So if I am starting cyclosporin, I think that's the right decision for that patient as far as management of their long-term disease. We know cyclosporin can take 4 or 6 weeks to see that full effect. I don't want a patient to be miserable, inflamed, itchy, whatever I'm using the cyclosporin for, while I wait to see if that is an effective drug for them or not. So it's very common for us. I tell owners kind of like a bridge. Like, it's very common for us to bridge over a short course of anti-inflammatory steroids just to provide some quick comfort, allow the cyclosporin time to have an effect, and then slowly try to taper away from the steroid and see if that cyclosporin can take over for us. Another situation I think about this in the clinic, if I am starting a dog with an autoimmune disease on azathioprine. Azathioprine is not a quick medication. It can take a couple of months to see the full effect. We have to watch for a lot of side effects with that medication. So if I'm managing, say, a pemphigus case and I need them on something while I see if I can get them on azathioprine long-term, or maybe another med like mycophenolate long-term that's not fast, then we'll often use steroids to provide that relief or control, even if we're having to stay up a little higher than we'd like. And that's why we're trying to switch to another medication in the first place. In cats with autoimmune diseases, this happens a lot for me when I'm switching them to Leukeran. I don't have to use Leukeran very often, chlorambucil being the drug name. I don't have to use that super often in things like pemphigus foliaceus, but I do have a handful of cats I've had to use it in, and I do use steroids usually while we're trying to get them started, knowing that's a medication that can take a couple of months to work. So while waiting for a slower medication to have an effect, we'll often use some steroids just to provide some sort of relief, even if it's not perfect, while we wait to see if that's going to be a drug that works for them or not. Number three, and this is probably one of the most common ways that you will see us in dermatology use steroids, stenotic ears. When those ears, you have heard me time and time again talk about this on the podcast, when those ears are swollen shut, you can't even get an otoscope in them, you can barely get a swab down them, and they're pliable, meaning they are not calcified, and you have a chance to open them up medically, then steroids are the way to go if it's not contraindicated. Putting them on NSAIDs maybe is going to help a little bit with the pain, but it's not going to open up that ear canal. And we obviously can't use the two together. So putting them on steroids is going to make that ear canal open up. It's going to make them feel a lot more comfortable. Sometimes I even make them wait a few days of just starting oral steroids before we start topical ear drops, just to allow some of that inflammation to go down so the eardrop actually goes in the canal, and so that pet's not so uncomfortable when they try to put a topical in. So that's probably one of the biggest ways you will see us use steroids is when their ears are stenotic. Now, I'm not saying every case of otitis needs steroids, because it doesn't. There's topical steroids in a lot of our ear drops. If they're just a standard allergy case doing pretty well, they get an ear infection. It's not like they're swollen shut. They just have, mild to moderate inflammation and an infection. Just by treating that infection, they'll probably feel better. Plus the topical steroid you're likely to put in that ear. But when they are swollen shut, stenotic, edematous, and you have a chance to medically help them, and you don't have to send them to surgery because it's calcified, then oral steroids are probably the best way to go to help open that ear up. Number 4, and this is an obvious one, but hey, for completeness, let's put it on there, and that is management of autoimmune diseases. Now, there are lots of cases I have been able to get off steroids long-term. I have pemphigus cases that I've successfully managed with cyclosporin or even off-label use of a JAK inhibitor or some other combination. But to get them under control, and oftentimes for some of these cases long-term, they do need a little bit of steroid. But when they are coming in and they're in a full-blown, let's say, pemphigus flare, most of us are going to start a steroid to at least get a hold of that disease process, and then start the steroid-sparing medications to see if we can make our way off of steroids in a perfect world, or at least be able to minimize the dose of steroids. Remember, everything with steroids, very dose-dependent drug. You can have cases on low-dose steroid long-term, and their lab work will look good. They'll tolerate it well. But if we're up in that autoimmune, immunosuppressive dosing, like 2 mg per kg of steroids a day, of course, you're going to increase the chance that you're getting a lot of those side effects. But if you can taper down to an effective dose, monitor their lab work, many will do fine on it long term, as long as you're being thoughtful. Because there are some that are really sensitive, right? We've all had the patient, we don't even put on that high of a steroid dose, and they're just getting PUPD all over the place. So they're all individual as far as the side effects they have, but we are very, very likely to be able to minimize those side effects if we can use lower dosing. So we'll often start higher, as you guys are all probably used to, get that inflammation under control, get the disease under control like pemphigus, and then try to reduce our dosing down to the lowest effective dose or transition them to another medication if we can. But when they are in that really full-blown autoimmune, flare, or you're just diagnosing them, then majority of the time we're going to use steroids because they're so effective. Number 5, this is real life. I deal with this too. Cost concerns, severe cost concerns of the client. Now, let me preface with saying there's a lot of times that if you manage their allergies appropriately, let's say you're going to put them on a JAK inhibitor, and maybe that cost seems like a lot to the owner, but then if you explain, hey, if we control your dog's disease better, we might not have to see your dog as often for flares. So we're going to save on veterinary visits. We don't have to do cytologies all the time. We're going to save on that. We're going to save on antimicrobials. Like, there are a lot of cases where if we can control their disease better with one of those medications and take away the other costs with it, that it's actually more cost effective for that owner. But of course, we have cases too that all the other therapies we have, monoclonal antibody, JAK inhibitor, cyclosporin, is just too much on a month-to-month basis. I would rather have that patient on hopefully a low effective dose they're not having a lot of side effects with, monitor their lab work appropriately, which for me, an ongoing case, if lab work looks okay, we try to check them a couple times a year, CBC Chem UA. But I would rather manage them with a low-dose steroid if they're tolerating it well than nothing at all. And the quality of life for that pet and that owner is terrible. So we do have cases where, they really can't afford anything else, and we do the best we can. We find the lowest effective dose, and that is okay. I would much, much rather have them have a good quality of life, monitor things, still educate owners of what to watch for, like flares, but give a quality of life to them and their pets. And we use, and especially cats, right? Because we're so limited on what we have with cats. We have lots of cats who have to be on low dose steroids, and we just do our best to monitor for the obvious side effects that we can see. Last one. This is a good one. Maybe you're not thinking of, but this is real life. And this is where I tend to use them a lot as a dermatologist, right? A specialist, where we do tend to get people who are really committed to trying things. Nothing else works. Nothing else works. It just happens. These are complicated disease processes that we are dealing with. I have cases where it's not for lack of me trying. It's not for lack of the owner trying. It's not for lack of the pet trying, because they'll actually take the meds. But we just get really tough cases where they fail Apoquil, they fail Zenrelia, they fail cyclosporin, they fail immunotherapy, they fail the supportive stuff. And some steroids provides the best relief we can. So sometimes it's not just they can't afford anything else, that the owner is not compliant or not trying. Sometimes we just got tough cases. We just have tough cases, and that is what provides that quality of life. And sometimes it's not even perfect, but it's like the best we can get to. And that happens. So I just want to provide relief that even as a specialist, that happens to me too, where my owners do all the things I ask them to do, and they just have a dog or a cat with really tough disease process. I have some right now where we're waiting for the next medication to release because they're just still not responding to all the tools that I have. So it happens to us. It's going to happen to you. Nothing else is working. You've tried all the things, and sometimes we just have to say, hey, let's monitor steroids the best we can. Let's provide the quality of life the best that we can. And that's a tough situation to be in. None of us like to have to say you've tried everything and it's not working. But again, it's real life and it happens. So The top reasons I want you to understand, even as a specialist, we use steroids to, not be so afraid or feel guilty about using steroids when you're in these situations. Number one, very severe inflammatory dermatitis that you feel like that dose of steroids is going to provide a lot of relief and comfort for that pet. Number two, you're starting a medication that has a slow onset. So you need something to bridge over to that because you don't want the pet to be miserable while we wait to see if that helps. Big one, number three, really stenotic ears that are not calcified and we think we can open them up medically. Number four, autoimmune cases, especially when we are in that induction phase of starting their treatment and they really need some relief. Number five, severe cost constraints. We want to still provide a quality of life for those pets and those owners. And the last one, nothing else works. You've done your due diligence, you've done the workup, you have done the appropriate things. This is a pet with complicated disease, and they just need some steroids to have some stability in their lives. So I hope that's helpful because sometimes I get asked about steroids as I go to conferences and speak, and it is really important. And I want you guys to realize that even as specialists, we do use steroids. Now, we have other medications if we're able to, right, that have less side effects, that are better tolerated. So you always have to find the balance. You really want to try to practice the best quality medicine and offer the other things. But I also don't want you to be afraid to provide relief in these situations where it can make a big difference. So hopefully that provides some clarity, maybe some relief, maybe a little lift of burden from having to be in these situations, because I face these all the time too as a clinical dermatologist.